Thank you, Mr Davis. I wanted to start by expressing my thanks to Mr Speaker for allocating time for this important subject. I also wanted to thank and pay tribute to the excellent Muscular Dystrophy campaign who do such brilliant work in this field and have been a considerable assistance to me in preparing for this debate. This morning, I will be bringing to the attention of the Minister significant gaps in accessing specialist neuromuscular care services in the North West region that many people living with muscular dystrophy and related neuromuscular conditions currently experience. Vital review work, which has been undertaken by the NHS North West Specialised Commissioning Group in the last 6 months, is encouraging, but families need to see this translated into real improvements to services. It is also an opportunity to improve patient outcomes and to reduce the amount of the money being spent on unplanned emergency admissions to hospital for people with neuromuscular conditions in the North West. I would like to briefly outline my own personal connection to muscular dystrophy. I am 47 years old, and I had a cousin, Stephen Payne, who, if he was still alive today, would be of the same age. He was diagnosed with Duchenne muscular dystrophy at the age of 6, and I remember the devastating effects that it had on our family at the time. This is the late 1960s, and not a lot was known about the condition at the time, and I remember my uncle, Mr Barry Payne, taking his son down to Harley Street to try and find out what the diagnosis was, and I'm afraid to say it wasn't good. But Mr Barry Payne is a fighter and a campaigner, and he threw all his energies into fundraising to see if there could be a cure found for Duchenne. My very earliest memories, therefore, are of a family fighting and campaigning to see if we could get a cure for such a dreadful disease. I also have very early memories of politicians getting involved in this vital subject. I'd like to pay tribute to Lord Alf Morris of Manchester, who at the time was the MP for Wythenshawe. And there was a wee bit of a coincidence because Lord Morris's sister lived on my council estate, and I remember at a very early age of him driving onto our estate in his Worsley car. And at the time, these Wolseley cars were for very, very special people. I remember him coming down to see my family and to visit his sister, and I remember thinking at the time what a very, very special man he was. In those days, in the 60s and the 70s, politicians were seen as people that could help ordinary people from working class backgrounds such as mine. And I remember so well the work that my family and Mr Morris did to try and get the country to change legislation. And I'm very pleased to say that in 1970, Alf Morris was the gentleman behind the 1970 Chronically Sick and Disabled Persons Act, which was the first act in the world to give people with disability rights. I, for my part, did my best to raise money for the Muscular Dystrophy charity, and I used to sell pens, pencils, rulers and pencil cases in the schoolyard at my primary school. And if you can imagine today, any head teacher allowing any child to go into school with a bag full of goods to sell for cash to take her home, I don't think it would be allowed in these politically correct times. But there was a coincidence there because my head teacher lived next door to my cousin, Stephen Payne, and he used every opportunity of school fairs to try and raise money for muscular dystrophy. My uncle, Mr Barry Payne, continued to campaign to raise money and awareness, and I have to say there were many occasions at airports and at museums where people in wheelchairs were not allowed access, and there used to be considerable arguments at the entrances of these places because he rightly felt that people with disabilities should be allowed. And I'm very glad to say that in the 21st century things are a lot different. Stephen was a bright and articulated individual and always forthright in his opinions, and he was a Manchester City fan and I was a Manchester United fan. And I remember clearly when Manchester United got relegated in 1973, he certainly let it be known how pleased he was about that. He died when he was 21 in California in America, and his peers died when they were in their very early teens. So it just goes to show that the treatment that you can get with palliative care and hydrotherapy can extend the life of people with Duchenne. The Muscular Dystrophy campaign is the leading UK charity focusing on all neuromuscular conditions and is dedicated to improving the lives of all people affected by these conditions. Founded in 1959, the Muscular Dystrophy campaign funds vital research, provides and supports care services, and also gives information, advice and direct help to individuals living with those conditions. I'm honoured to be a member of the All-Party Parliamentary Group on Muscular Dystrophy, which has highlighted shocking gaps in service across the UK and continues to call for improvements in access to specialist neuromuscular care in following up the recommendations put forward in the Walton report. There are more than 60 different types of muscular dystrophy and related neuromuscular conditions. It is estimated that over 1,000 children and adults for every 1 million of the population are affected by muscle-wasting neuromuscular diseases in the North West. Therefore, it is estimated that around 8,000 people are affected by neuromuscular conditions in the North West region. These disorders can be genetic or acquired. A number of the conditions, such as Duchenne muscular dystrophy, are particularly aggressive. They cause progressive muscle wasting, weakness, orthopaedic deformity, cardiac and respiratory compromise, and result in premature death. Many young boys in the UK with Duchenne muscular dystrophy are dying before they get beyond their teens. This is quite simply unacceptable. Specialist multidisciplinary care has been developed by leading clinicians as the best model for delivering effective care for such complex multi-system diseases. The provision of expert orthopaedics, early cardiac monitoring and intervention has been shown to improve muscle function and maintain independent mobility. People with neuromuscular conditions, therefore, need this specialist multidisciplinary care and support for intervention from a range of professionals and specialists. This was recognised as part of the Specialised Service National Definition Set, and the leading neuromuscular clinicians fought hard to get these recognised by the Department of Health as specialists. Specialised services are defined in law as those services with a planning population of more than 1 million people. This means that a specialised service would not be provided by every hospital in England. The SSNDS described these services in more detail. The definitions provide a helpful basis for service reviews and strategic planning and enable commissioners to make comparisons on active levels and spend. The definitions help with the identification of activity that should be regarded as specialised and therefore subject to collaborative commissioning arrangements. The 10 specialised commissioning groups, acting on behalf of the members of PCTs, are responsible for the commissioning arrangements for specialised services. The neuromuscular conditions come under the auspices of a number of specialities. They are genetic conditions, hence genetists are sometimes dealing with patients. They affect children and therefore paediatricians are involved. A number of adult forms come under the heading of neurology. Some of the conditions require respiratory care, and this is provided by a respiratory practitioner, and some are metabolic conditions such as POOM. The patients are treated by specialists for metabolic disorders. Therefore, healthcare for people is quite fragmented, and this clouds professional responsibility. Neuromuscular must be recognised as a speciality along with neurology. Dr. Ross Quivlan, a leading consultant in paediatrics and neuromuscular disorders, has outlined the effects of neuromuscular conditions and how they need to be managed. Neuromuscular conditions are rare and include muscular dystrophies, metabolic myopathies, congenital myopathies, inflammatory myopathies, spinal muscular atrophies. Many of these conditions affect only skeletal muscle and thus cannot be considered to be neurological disorders. In fact, skeletal muscle can be considered to be the largest organ in the body. Most neuromuscular disorders are genetic in origin and affect families, but the inflammatory myopathies are acquired and require specific treatment. Affected patients range from newborn infants to elderly people. The effect of many of these conditions is on the skeleton, causing skeletal deformities due to muscle contractures, and on the heart and lungs, causing respiratory and cardiac failure, which can significantly limit life expectancy. The physical management of these disorders is quite distinct compared with conditions affecting either the nervous system or the musculoskeletal system, bone and joints. Proximal and axial muscle weakness causes specific functional difficulties not seen in patients attending clinics in other specialist areas. The progressive nature of these conditions means that a multidisciplinary approach to care with experienced clinicians specialising in neuromuscular disorders is essential for best outcomes. However, it is now felt by the clinical community that it is time to implement a neuromuscular curriculum into the medical career to give this field its own right. The conditions have a lot in common, that it makes sense that they are handled by the same person. For example, some forms of limb girdle muscular dystrophy exhibit similar symptoms to some forms of spinal muscular atrophy. However, one is a muscle disease, the other one more a neurological disease. These are long-term, rare conditions which makes them quite different from neurological diseases such as Alzheimer's and Parkinson's. Neuromuscular services need to be commissioned on a regional basis, currently by the 10 regional NHS specialised commissioning groups, with top slicing of the PCTs. This method of commissioning these rare and very rare conditions has been endorsed by a new body of experts, the British Myology Society. It makes no sense for one PCT to commission specialised services. Unlike conditions such as Parkinson's or multiple sclerosis, there are no NICE guidelines, which presents real difficulties when trying to set standards of care for neuromuscular conditions across the country. This has been a contributing factor to the postcode lottery which has arisen and has been highlighted in the APPG for Muscular Dystrophy's Walton report, published in August 2009. This followed muscular dystrophy campaign reports as part of the charity's Building on the Foundations campaign, which revealed the shocking lack of specialist care in many parts of the country. The lack of knowledge, training and skills is a significant concern. For example, there is no specific training or curriculum for neuromuscular services in the neurological field. I'm sure you will share my concerns and frustrations of people living with neuromuscular conditions in the North West from the Muscular Dystrophies Campaign's patient survey in 2010. Deborah Hurst from Liverpool is affected by FSH muscular dystrophy, but was not diagnosed until she was in her late 30s. She's now 47. Her two daughters were born before her correct diagnosis was made, and one of her daughters has inherited the condition, now aged 25. And I quote, she says, "I have two daughters and I knew one was affected, but the doctor told me I was fussing and silly. When I finally got them tested, he congratulated me on my actions, which I was very mad about, as my daughter took her diagnosis very badly at the time, and congratulations wasn't what we wanted to hear." Mrs. H from Lancashire has a son affected by a neuromuscular condition. She says that in her experience, GPs do not understand the condition. My GP, quoting, my GP is very good, but says we have about 2 hours of tutorial on muscular dystrophy in the whole medical training, so therefore they have no in-depth knowledge. Elaine Sands from Stockport is affected by FSH muscular dystrophy. She does not receive any specialist care, but would value the support of a neuromuscular care advisor. And she says, as I'm housebound, it would be nice to have someone give my physiotherapy and also some kind of visitor who knows about my condition, as I live alone and would appreciate being able to talk to someone who understands the disease. However, the situation is different for Joanne Ashton. She has a 5-year-old son, Liam, with Duchenne muscular dystrophy. Through the specialist neuromuscular service at Alderhay Hospital, Joanne and her family have access to a specialist consultant, Dr. Stefan Spinty, and a full multidisciplinary service including a neuromuscular care advisor. Joanne says, "Shirley, our care advisor is fantastic. We only have to ask and she's there. Liam had his wish granted through the Make-A-Wish Foundation because he was nominated by Shirley, so we are all impressed with the care advisors." The Muscular Dystrophies Campaign, clinician-led Building on the Foundation North West report, published in June 2009, uncovered the following findings about neuromuscular services in the North West.
Thank the member for giving way and congratulate him on succeeding in getting the debate. On the issue of care advisors, which he has rightly alluded to, does he agree with me that right across, and I understand obviously that the North West of England is his particular concern, but right across the United Kingdom, if more emphasis were placed on having excellent care advisors like the one he has just alluded to in his quotation, that would help those who suffer from this condition immensely in trying to come to terms with it?
Graham Evans.
Thank you for that intervention. I wholeheartedly agree. When you're suffering with something, there's nothing quite like having people who are trying to help you that actually physically and mentally understand what it is you're going through. So I wholeheartedly agree. 3 out of 4 patients and their families have no access to key worker or care coordinators. Regional care advisors, 6.5 regional care advisors are needed to serve the estimated 6,500 now estimated to be 8,000 people in the area with a neuromuscular condition, many of whom are simply not known to providers of health services. Patients are very limited access, in particular to ongoing physiotherapy. Specialist physiotherapists are required to support outreach clinics and provide training and professional development for community physiotherapists. 2/5 of patients in the North West state that they do not receive enough physiotherapy. There is no dedicated physiological services for neuromuscular patients, despite its importance as part of multidisciplinary care for this patient group, with rare and very rare progressive conditions, often genetic in origin and with no known cures and only limited treatments available. Greater support at transition from paediatric to adult services is needed, given the evidence of services being removed or greatly reduced when people leave paediatric services, even though needs may well increase given the progressive nature of many of the conditions.
For giving way. Congratulate you on raising a very, very important subject, in fact posing a very, very significant problem. If I understand him correctly, what he is saying is that we need an adequate clinical network for a rare disease of the kind he's spoken about. And a range of providers need to be, as it were, joined together seamlessly in some way for the good of the patient. And that these pieces, normally, we expect the SHA to identify and for them to somehow or other levy the PCTs in order to deliver a seamless service, which I think is what the patients expect and deserve. Is he posing the central problem of how will this progress under the new arrangements when PCTs, SHAs and organisations like that mandated to resolve these problems are no longer there?
I thank my honourable friend for that intervention. Yes, he raises a very good point. It's a threat, but it's also an opportunity, because during the current provision with the PCTs, not all PCTs understand the condition. And as I'll be coming, and this is a real opportunity for the muscular dystrophy charity to get their point across so that we can get off on the right foot when the changes do come in. But the GP consortia really do need to understand and appreciate what is required. It's about a holistic approach. And I'll be coming to shortly in my speech about an excellent neuromuscular centre that we have in Cheshire, which makes a huge difference, and it does encompass physiotherapy and the other aspects that make life so more comfortable for those with muscular dystrophy.
Member, and to you, Mr. Davis, I'll not be able to stay the duration of the debate, so I'll not find the answer to the problem that I think we're posing.
Okay, thank you.
Yeah. George Hollingbury.
Thank you, Mr. Davis. And I do apologise for intervening so immediately after the previous one, but you just raised an interesting question about the transition from paediatric services to adult services. And in the South Central region, clearly outside the topic of this debate, but in my own area, we have recently managed to secure an advertisement, at least, for a new care advisor in the area. But I understand that this care advisor will not be able to advise on paediatric conditions, but actually only on transition and adult services. Is it not the case that we need a full range of services for all sufferers of this disease and proper range of advice across all ages?
Graham Evans.
Thank you. My honourable friend raises a very good point, and I totally agree. It's a holistic approach, and it should be a seamless transition from being a young person to an adult services. But it's not just muscular dystrophy. Lots of mental health care, for example, suffers from very, very similar aspects. But you're quite right. It should be a seamless transition from one to the other. Greater support at transition from paediatric to adult services is needed to give the evidence of services being removed or greatly reduced when people leave paediatric services, even though needs may well increase given the progressive nature of many conditions. There is a 3-monthly transitional clinic at Manchester and a monthly transitional clinic alternating between Alderhay Children's Hospital and the Walton Centre in Liverpool. Both services are extremely vulnerable and entirely dependent on the availability of the respective consultants. A transitional clinic at Preston is currently involved, but based on the goodwill of the clinicians involved and not formally funded. The transitional clinic at Alderhay Children's Hospital is the only one that is attended by the required multidisciplinary team. None of the transitional services in the region are funded or appropriately staffed. The Walter Report, published in August 2009, expressed the concerns of the All-Party Parliamentary Group for Muscular Dystrophy as a result of the inquiry into access to specialist neuromuscular care. Martin Blenkarn, chair of the North West Muscle Group, expressed his frustrations in written evidence to the APPG about attempts to access NHS physiotherapy. No hydrotherapy available in the area. Private arrangements can be made, but no assistance from NHS physiotherapists can be obtained. Compared with the previous PCT area, North Cumbria, which covered the area where he previously lived, the service in his current PCT area, North Lancashire, is totally unsatisfactory. The quality of care from those who treat him directly is fantastic, but their hands are tied to provide what is really needed. The all-party parliamentary group concluded in its regional summary about the NHS North West region. We heard from clinicians in the North West region about the problems facing the multidisciplinary North West Neuromuscular Network, founded and chaired by Dr. Stefan Spinty, consultant paediatric neurologist and lead neuromuscular clinician at Alder Hayes Children's Hospital, Liverpool. Dr. Spinty is currently managing this vital network single-handedly without any funding. We believe that the network should at least be supported by a network coordinator. Greater support at transition from paediatric to adult services is also needed, given the evidence of services being removed or greatly reduced when people leave paediatric services. Existing transition services are extremely vulnerable, and we are concerned to learn from clinicians that none of the transitional services in the region are funded nor appropriately staffed. Having met with commissioners from the North West Specialised Commissioning Group to discuss these concerns, local clinicians and representatives from the Muscular Dystrophy campaign were disappointed to be told that there are competing priorities in the region and that PCT budgets are under strain. We urge the North West SCG and the local PCTs to undertake a service review to address the weaknesses highlighted by clinicians, patients and the Muscular Dystrophy campaign. The NHS North West Specialised Commissioning Group has taken significant steps forward since these findings by the APPG, which I will outline shortly. The Muscular Dystrophy campaign's North West Muscle Group, chaired by Martin Blenkarn, raises awareness of neuromuscular conditions and provides a forum for people living with the condition to share experiences and advice about access to local and regional services. The group has been actively campaigning to improve the access to neuromuscular services in the region, engaging with MPs and the NHS North West Specialised Commissioning Group since the Muscle Group's launch in June 2009. The North West Muscle Group's pressure, alongside the Muscular Dystrophy campaign, and the all-party parliamentary group for muscular dystrophy was instrumental in ensuring that the North West Specialised Commissioning conducted a thorough review of neuromuscular services. Joanne Ashton, a member of the North West Muscle Group, commented, "I'm glad I joined the Muscle Group. It means I've got all the information early on and I won't come up against a brick wall later. I feel I've been pre-armed. It's nice to know I'm not on my own and it's good to meet other people at different stages. Every day I imagine how bad things could get, but at the Muscle Group I met young lads with Duchenne muscular dystrophy who are in wheelchairs and they're fantastic. They're doing so well. Everything had a real positive spin on it too, and I realised that it's not all doom and gloom." The campaign in the North West was spurred on further by the comments of Mike Farrer, NHS North West Chief Executive, to Lord Walton of Detchant, an event in Parliament in November 2009. Having referred to the South West review of the neuromuscular services with Sir Ian Carruthers, NHS South West Chief Executive, pushed through Mike Farrer's comments. "Anything Sir Ian Carruthers can do, we can do better." As a result of lobbying by the Muscular Dystrophy campaign, a review of services was set up in the South West Specialised Commissioning Group in February 2008. In February 2009, local primary care trusts approved a new £1 million neuromuscular strategy in order to reduce the £6.9 million spent in the region on unplanned emergency admissions to hospital for people with neuromuscular conditions. In my right honourable friend's constituency of Eddisbury, as I mentioned earlier, I am fully aware, as are several other honourable friends, of the excellent work that the Neuromuscular Centre in Winsford, Cheshire, does, both in terms of ongoing specialist physiotherapy, reducing the number of falls for people with neuromuscular conditions and the social enterprise opportunities which it offers. However, while the physiotherapy provision is regarded as excellent by those who go to the NMC, there are difficulties which are encountered with PCTs and funding. as reported in the Muscular Dystrophy Campaign Patient Survey 2010. Mr A from Cheshire has Charcot-Marie Tooth disease and travels to the Neuromuscular Centre in Winsford for specialist physiotherapy and hydrotherapy. However, his local PCT is unwilling to pay for this, despite not offering him any alternative physiotherapy or hydrotherapy provision. Following concerted pressure by the Muscular Dystrophy Campaign, the North West Muscle Group campaigners and the APPG for Muscular Dystrophy, John Devling, Chief Officer of the North West Specialised Commissioning Team, personally committed to the APPG for Muscular Dystrophy in January 2010 that he would recommend that the North West Specialised Commissioning Group undertakes a review of neuromuscular services. The review of services was set up by the North West Specialised Commissioning Group in May 2010, and the steering group set up an effective model of the NHS working with muscular dystrophy campaign, patients and expert clinicians from the region. To further involve people living with neuromuscular conditions, a stakeholder day was held in September 2010, and this represented a vital opportunity for people to have their say about the services which are vital for an acceptable standard of specialist neuromuscular care in the region. This led to a gap analysis and report with recommendations of service improvements, which was the first time ever that neuromuscular services have been looked at in this way across the whole region. The recommendations are currently being put to local primary care trusts to approve new investment for a neuromuscular strategy. The proposed minimal required investment to reduce the 13.6 million spent on unplanned emergency admissions to hospital for neuromuscular conditions and to sustain neuromuscular services across the North West includes 2.5 new fully NHS-funded care advisors, 2.5 specialist consultants, 2 to 3 specialist physiotherapists, 1 specialist neuromuscular nurse. Will the Minister agree to write to the Specialised Commissioning Group and PCTs, endorsing the recommendations as necessary steps to save money and reduce unplanned emergency admissions? Will he ensure that a named individual in the NHS in the North West will take this work forward once the specialised commissioning groups disappear? The neuromuscular network approach is hugely important to ensure coordination of neuromuscular services in the specialist multidisciplinary team, as demonstrated in the southwest of England and the Scottish Muscle Network, as well as links to the primary and secondary care, which play a crucial part in the management of neuromuscular conditions. Dr. Stefan Spinty, consultant paediatric neurologist at Alderhay Hospital in Liverpool, who played a leading role in the North West Neuromuscular Service review, said, "In order to improve patient outcomes and help to reduce unnecessary and costly hospital admissions, it is important that the recommendations from the North West Specialised Commissioning Group report, which is due to be published soon, are implemented. All neuromuscular clinicians who have been involved in the North West Neuromuscular Service review are committed to support the implementation process to further improve and secure service provision for individuals affected by neuromuscular conditions in the future." Christine Ogden, a campaigner and fundraiser from Bolton, whose grandson has Duchenne muscular dystrophy, said, "It is vital that essential increase in care, support and advice for families outlined in the North West Specialised Commissioning Group's report recommendations, which will make a real difference for families living with muscle disease. It is also so important that information for health professionals and about neuromuscular conditions is significantly developed." Beryl Swords from Liverpool, whose son John has FSH muscular dystrophy, has commented about the provision of physiotherapy for adults with neuromuscular conditions. "I feel strongly that physiotherapy for adults with muscular dystrophy is totally inadequate. If improvements were made to North West Neuromuscular Services, then perhaps this area of care could be more freely available, keeping people with the condition mobile for longer." The urgency of improving neuromuscular services in the North West is encapsulated in the following comments from Nikki Geraghty, a North West campaigner and fundraiser whose nephews have Duchenne muscular dystrophy. "I have 2 nephews with Duchenne muscular dystrophy. This is not only a cruel condition for my nephews to suffer from, but also very harrowing at times for us as a family to watch each stage of progression, knowing that the postcode lottery already exists throughout the country. This has a huge impact on survival rates, and I don't wish to see my nephews robbed of any chance that they have to lead the best of life possible." The evidence provided makes a compelling case for the necessity and urgency of developing and improving neuromuscular services in the North West in order to save money. Will the Minister write to NICE stressing the importance of a NICE quality standard for Duchenne muscular dystrophy, as well as one on home ventilation and respiratory support? Will he attend the next APPG for muscular dystrophy session on Wednesday the 9th of March to update the group on progress? Will he agree to meet with clinicians who have been developing a neuromuscular curriculum together with the Association of British Neurologists? Thank you, Mr Davis.